Okay, welcome everybody to session 4. Today we are going to be talking about allied health and support staff, specifically medical assistants and community health workers, and building HPEP programs and pathways to bring those folks into your health center team. So just a reminder to everyone, the slides from today's session will be available on our discussion board after the session, as well as a recording a little bit while later once that renders. And then the coursework will also be posted on there. If you have any issues accessing the discussion board, just let me or Mariah know and we'll get you taken care of. And then as always, we are here on behalf of the Association of Clinicians for the Underserved, and specifically our STAR Center program, the Solutions Training and Assistance for Recruitment and Retention program, which is a BIPIC-funded NTAP, National Training and Technical Assistance Partner. And so everything produced through the STAR Center is free for all of our health centers. And then here's the STAR Center team. And today you have myself, Helen, and Mariah. And Mariah will be helping out with all of the technical stuff. So if you have any issues with Zoom today, feel free to send her a message and she'll get you taken care of. And otherwise, today we are going to look at building community health worker and medical assistant HPEP programs and kind of understand the opportunities that they provide, obviously, to recruit those specific positions, but then also the fact that those positions can grow into many different roles in your health center. And then we've talked a little bit about funding opportunities in the past, and just the other day, I noticed one of the emails that I get from one of the HRSA newsletters. And so for anyone looking for funding opportunities and wants to stay on top of that, this slide will be in the presentation, and it has a link to HRSA's newsletter on funding opportunities, and they are routinely announcing new funding and everything. So if you're not signed up for that, you can follow the link in the slides when you download them, and this will take you right to the newsletter sign up. And I think that's a good resource, especially if you're considering some of the like advanced practice provider and nurse practitioner and then physician HPEP programs. They usually have funding to support those. And then let's see, how many folks do we have with us today? 11. Instead of breakout rooms, let's just do a group discussion if that is okay with everyone. And does anyone have any thoughts on the coursework from before? We started to do the cost assessment and thinking about the costs of producing an HPEP program or expanding one versus the cost of turnover. And I'm especially curious, has anyone looked specifically at cost of turnover for different types of staff and kind of compared that to the cost of implementing different solutions for retention or recruitment?
This is Joan Lane from Southwest Community Health Center in Bridgeport, Connecticut. And I was reading one of the things that was posted in your resources, and it said that the net worth of losing an RN is $46,100. So I thought that was pretty impressive sum.
Mm-hmm. And you know, it obviously depends on a lot of different factors. We also have the physician. It's kind of geared towards providers and advanced practice providers, but the turnover tool for that, and if kind of looking at the time period to you know, go through the kind of offboarding process, right? If an employee leaves, say they're retiring or whatever, and changing out all of their access and privileges and everything, and then onboarding a new one, plus the search period in between with that loss of revenue, the cost of turning over, say, a physician can be upwards of $300,000 in some cases. So it can be a significant chunk of money, especially when it comes to thinking about like, okay, how are we going to do salaries and benefits and other kind of retention measures, or implement something like a health professions education and training program. All right. Well, and I know we have a small group today, so I think because we have some really fantastic presenters with us, what I will do is move us on, and I will turn it over to Elena here to talk about medical assistance. And Elena Thomas Faulkner is the Chief Executive Officer and School Director for the National Institute for Medical Assistant Advancement, NEMA. She has over 20 years of experience in organizational leadership, management, and development to her role at NEMA, in which she's responsible for advancing NEMA's mission of providing high-quality, accessible medical assistant training to individuals in medically and educationally underserved communities, and to meeting a critical workforce need for medical assistants prepared to support integrated team-based primary care. Elena has worked with community health centers in a variety of capacities, including as leadership in the Colorado Primary Care Association and as a consultant providing support on strategic planning, strategic decision-making, payment reform, value-based payment strategies, and capacity building. Elena also serves on the Colorado Department of Education Healthcare Stackable Credential Pathways Leadership Team and regularly presents on medical assistant career and education pathways to national audience. So Elena is just a tremendously credentialed person, and I'm really excited to have her here today. And so I will turn it over to you, Elena. Let me stop sharing my screen.
Thank you, Alex. It's great to be here, and I'm excited actually that we have a small group, so hopefully we can engage in some discussion as well. I do have a lot to share, and really despite those credentials, I'd say most of what I'm going to share is what we've learned through NEMA, working with community health centers and other safety net providers to deliver medical assistant training. So it's what we've learned from our clinical partners that I'm really highlighting today, and reflecting back to you as you think about developing a health professions training program or new aspects to the program that you already have. So really trying to focus my points today on this assessment and planning perspective and sort of thinking through what the options are and what the resource and financial costs are to those options. I'm going to keep within 20 minutes, since I'm going to move pretty quickly, and looking forward to time to talk after the presentation as well. So wanted to really orient or provide kind of a pathway of some questions that would help think through, particularly in terms of medical assistant training, what are the things that you want to consider? And I'm sure these are the things that you've been looking at over the time of these sessions that you've had together already. These are iterative steps. They're not necessarily sequential, but I think these are the key things that you want to ask yourself, and that I'm focusing the conversation around today. So first, it really is the why. Why are we wanting to educate health professionals? What is it that we're trying to accomplish? And I'll talk about that a little bit more in the other slides. Understanding what those current costs are, as well as what the cost of investment in training is. And then really looking at what the options are that are available. There are a number of different ways that this can be approached in relationship to medical assisting. And so understanding what those are and what the implications are for both how much you can tailor a program to your needs and also to what the resource requirements are of those programs if you were to implement them directly. And so related to that, one of the important steps is looking at, what is the capacity that you have as an organization and how does that fit in with the options that are available? And finally, wanted to be sure and talk about some of the funding that I'm aware of that's available to help support those efforts. So with that, and I would welcome if you want to put questions in the chat, I can try and respond to them while I'm presenting, but also feel free to jot them down and so that we can address them during the question and answer. So why are you pursuing an education option for medical assistants? And I would hazard a guess that probably everyone on the call can relate to the first bullet on here, which is sort of this immediate need. We don't have enough medical assistants. We have trouble hiring medical assistants. We have trouble keeping medical assistants. And that's really where most folks start. And that's a very important need to pay attention to. There are other reasons for pursuing medical assistant training that are maybe have a longer term perspective to them. So just thinking about what is the health center mission beyond delivering those visits, which is why we need the medical assistants, but what is the role of a health center in addressing the social determinants of health within the community, providing educational opportunities, providing pathways into a health career, and helping to diversify that healthcare workforce. So those are really important motivators as well for getting involved in health professions training, and would lead one toward maybe a more extensive program or more investment from the health center in some additional components of what a program might look like. And for some of you, you may already be partway down that path as a teaching health center or having implemented training for some other professions within healthcare that can really be leveraged to help support that role with medical assisting as well. And then we also see some of our healthcare partners really wanting to establish themselves as a preferred employer. So their engagement in medical assistant training is part of an overall perspective that we really want to be the place that people come to work and stay to work. And so our investment in this kind of training is part of that broader investment in making those opportunities available and providing that advancement opportunity for staff that we have already. So on that note, I want to just take a minute before we get into talking about training programs to refresh our thinking about medical assistants. I think particularly because often there is just that need to get the medical assistants on the floor to help support that visit with the doctor or the other provider, which is critical. But to think about it from the perspective of the medical assistant, where is this person coming from? What is their pathway into a health career? And what are their hopes and dreams for the future? And so we at NEMA educate medical assistants in 18 different states in partnership with 50 clinical partners. And I have the pleasure of reading through those applications that come in. We have about 200 students a year, and hearing the stories of those medical assistants, what they're aspiring to and what brings them to apply to become a medical assistant. And many of them come from this patient perspective or community member perspective. I received care at this health center. My family received care at this health center. The way I was treated, the interaction I had with a medical assistant here is what brought me into this desire to be a medical assistant. But the other place where we see folks applying from is an earlier role within the health center or within another clinical provider. Not typically a clinical role, so front desk, sometimes it's facilities staff, maybe working in the call center, but by virtue of that exposure to the health center, having the opportunity to see what the role is of medical assistants and really saying, I really want to get involved in that. I want a more hands-on role in serving patients. So that's a really important piece, and it ties in also to community health worker roles as well, which I know we'll be hearing about a little bit later. And then of course, most health centers have several roles for medical assistants. So there's those opportunities for advancement from a beginning medical assistant role to maybe a more advanced role or an MA lead. And we often think about that pathway that's more of a clinical pathway where an MA could go on and perhaps become an LPN or become an RN over time, perhaps be more involved in, we see a lot of specialization in the immunization clinic, really getting involved in monitoring that administration and the overall record keeping for that program. But and most of our students, I will say, when they apply to be medical assistants, talk about, I want to go on into one of these other roles over time. We know most medical assistants are in that role 3 to 5 years, and then we'll search for another opportunity. So we want to pay attention to what those long-term motivations are. Most of our applicants think about the clinical pathway when they're applying as a medical assistant, but you all know from your own experience, medical assistants move into all kinds of roles within the health center. So within that role, having the exposure to billing, to referrals, to care coordination, to behavioral health really opens up those other pathways. And so these medical assistant career possibilities are important, I think, to keep in mind when you're thinking about an overall workforce strategy and where medical assisting fits in there. So kind of that broader lens that can be in addition to kind of focusing on how do we meet this medical assistant direct work need. Okay. I'm not going to spend a lot of time on this slide because I think you all have been talking about this in your prior conversation. So on the right-hand side is really, what's that cost if we don't have the staff that we need in terms of productivity, in terms of retention, satisfaction, and of course, patient outcomes. On the left-hand side is sort of what are the investment costs, and what I want to try and walk us through a little bit today is what those can look like in different models. Often we think of the staffing in particular. So certainly if we're investing in health professions training, there is a need for preceptors, and that's kind of on the bottom of the left here. At a minimum, you're going to have someone that's working with students when they're in the clinic for a clinical experience. If you have a more extensive program, that could include, some trainers if you're doing some training, onboarding of staff when they're hired. And if you're coordinating with other resources in your community, certainly someone that has some sort of administration role. So that's kind of the implementation cost from a personnel perspective. The other places where we see health center partners investing in health education is around supporting that ongoing or initial education of staff. So our program, because we're a school, has a tuition cost. We have partners that step up and say, we're going to cover that cost of tuition for the students. Many health centers will say, I'll cover the cost of certification for medical assistants to take that national exam. Increasingly, health centers are starting to cover the continuing education and the recertification for medical assistants. We've covered that for clinicians for years, right? But it's just as important for medical assistants to keep their skills up and be able to keep up that certification. A much lesser cost for allied health staff, so something to consider as well. And then training stipends. And by this, to differentiate from kind of the education costs would be if you're training folks, paying them for the time that they are doing the training. And we'll talk about different models for that as well. But we know with the workforce environment that we have now and with the economic situation in many of the communities served by health centers, that ability to get paid while learning is a critical way to differentiate yourself as an organization from the other competing employers for those staff. Okay, this slide was my attempt. I had this whole scatter graph. Our slide designer said, let's just make it a little bit clearer. So hopefully it conveys what I was wanting to convey here, but really kind of if you think about on the bottom axis is, what is the ability to tailor an approach and really personalize it to your health center. And then on the left axis is really, what is the investment and the cost of that? So there are all kinds of options, and these, there's nuances between these, but just for the purposes of illustrating overall kind of how we conceptualize. If we start on the bottom left, if you're hiring trained medical assistants, that's pretty direct. So there's not really any investment for you as a health center other than probably retraining or orienting folks. But you don't have a lot of say in what is being, how they're being educated or what that information is that they're getting prior to coming on at the health center. You could certainly, work on some recruitment initiatives with partners in the community that perhaps that would be more of an effort as well. The second option here is hiring or hosting medical assistants and then hiring them. So many of you probably do this already, engaging with an education partner, having those students come on as part of their experience with their education, and then hoping to hire them as well. So that would be the more traditional cost of having a preceptor, maybe someone to help coordinate what that relationship is. Option 3 is really taking that and building on it, and that's the model that we use at NEMA, helping to support more of a grow your own model. So in our case, for example, and there's other examples of this as well, our program includes a very extensive externship experience. We also partner with our organizations in the interview process for students so that they're weighing in on, is this a student that we would like to have placed with us that we think is a good fit for the program? And then we invite our partners also to support, if they're able, either the tuition or some of the offset some of the costs for those participants in the program as well. So it's really marketed as, here's an opportunity to establish a relationship with a potential employer through the training process. And that's why we think of it as a grow your own, because we're really targeting those communities where our clinical partners are located to do that recruitment and bring their community members into the program, targeting then for them to be placed at the health center. You can do something similar with an apprenticeship model. And we also work with apprenticeship at NEMA, but apprenticeship can be just a little bit more formalized. So you're saying really this is a job opportunity, right? We're trying you out during this apprenticeship phase. And you can do that in partnership with an education provider. And what that allows is for someone else to do all the curriculum development, the skills checkoff development, those kinds of things, sometimes the sponsorship of the apprenticeship, so that what you're focusing on still as the clinical provider is more that experience that the individual has in the clinic. So a little bit more of a lift, because those tend to be more tailored, which if you have the capacity to do that, that's a great option. And then kind of far up on the right is completely in-house design and delivery. And I think sometimes what folks, the thought process goes from, we're not getting our medical assistants that we hire directly from our schools aren't what we need. So let's go up here to option 6 on the far right. We'll create our own, we'll design our own curriculum. And then what we find sometimes is sort of 6 months into that, it's like, oh my gosh, what are we doing? Like this, we're not an education provider, we're a health center. Now, some folks, certainly have the capacity to do that. They build a curriculum that works great for them, and that's wonderful, particularly if you have that education aspect to your organization already. But for others, these other options in between make more sense in terms of being able to have the resources to support them ongoing and to get them up off the ground. Or it may be a process where you start with one option and over time, build on to that to where you're able to tailor something more specifically for your needs. So a couple things to note about this from the student perspective, however, these first 4 options here on the left, because they're done in coordination with education provider, students can also earn post-secondary credit for that, college credit for that. So that's an important foundation for them to go on, both to get a certification exam of their choice, but also to have credits that they could then use to move on to another level of education. So for example, our graduates at NEMA, we have articulation agreements with some community colleges that allow students to basically use our training as half of their associate's degree in medical assisting. So they don't have to redo that work. And again, when we're thinking about those career pathways, that's an important thing to consider as well. These 2 on the far right can, as long as the content is there over time, individuals who complete those programs could take a national certifying exam. They need that on the ground experience to be able to do that. So they can get the CCMA certificate, but they won't have the college credits or the opportunity to take some of the other exams which require graduation from an accredited program. So as you're thinking about those options, I just sort of pulled this slide together to say, what are those resources that you have to support those? So the items over here in the light green, are pretty much any effort that you're doing are going to take some level of these resources, a preceptor to work with students, some level of coordination. As you get into more of designing your own solution or a collaboration that involves quite a bit of tailoring, you're looking at being able to support some of these other aspects that are on the left side of the graph. So funding sources. So if you're thinking about that, what are some of the funding sources that are available? And right now, there are a lot of funding opportunities. The question is, do they fit for what you're trying to accomplish, and how do you navigate those? So certainly a lot coming through the workforce pipeline and Department of Labor. And much of that is focused on apprenticeship type models, but there are certainly also one-time grant opportunities that can support a variety of models as well. So we're seeing a lot of local and state foundation grants to support workforce initiatives. As I mentioned, Department of Labor, which sometimes comes through your state Department of Labor or through the local and state workforce agencies. Sometimes it gets funneled through your city government or county government as well. So those are great places to look. And then I would say as leaders, thinking about how do you build your organizational budget to support some level of education and training over time, perhaps starting with those grant funds and then moving into something that's more self-sustained as you see those reduced costs of having to continually replace staff. And then just to note that students also are eligible for funding. So if you have a training partner that's on the state eligible training provider list, often students can get help participating in those programs with either the training cost or with supportive services. If you're working with an accredited education provider, students can then get access to federal student grants and loans, which can be helpful. And then again, sometimes with workforce or with employer support, having that support for either the hours spent in training or some other aspect of the training costs can be very helpful and very motivating. So when we look at NEMA, at how our partners invest in the training that we offer in partnership with them, there's really kind of two viewpoints that I wanted to summarize in this slide. One in terms of demonstrating that commitment to the community, which looks like, how do we partner with the academic institutions? How do we engage our local K-12 schools in learning about health careers? How do we engage with local workforce? And that really helps to create this pool of potential workers that are mission focused, connected to the health center. And then that investment in employees as well. So how do we make it possible for employees to take that next step in their education, whether that's supporting their tuition or helping them in modifying their hours or just encouraging them to take that next step. And we see that really supporting retention of employees. That can be through, service agreements that we ask employees to commit to, or simply just through the fact that they see, even if they're not participating, they see that it's something that the employer offers and they see the value in that. So I would just, this slide is just that encouragement to think about it again from the employer perspective, which is of course, we're wanting to make sure we have the staffing to deliver the services that we want to deliver and need to deliver in our communities, but also as you're developing the programs, think about it from the student perspective, what are they trying to accomplish over time and what helps facilitate their participation given the life circumstances that they have. I'll just close with this picture, which is one of my favorites that one of our partners sent us of graduation, student graduation. And I think really kind of sums up, I think you can see the emotion in the picture, both for the students and also from the staff. This was their first cohort of students that graduated with this particular partner. And the energy that comes from investing in health education and engaging staff in these programs, I think is invaluable. And so I'm so thrilled that you all are looking into putting those into place. Stop there.
Fantastic. Thank you so much. And we'll give a few minutes here if anyone has questions for Elena.
Loved your presentation.
And I have one question that kind of did come up to me, and if it's okay, I'll ask real quick, is with the, so going back to, you had the graph of all the different kind of levels of basically how much input you have to provide as a health center versus how much kind of control or direction do you have out of the program. Is there kind of anything along that where it's kind of you have a lot more opportunities for funding? Because I know like there were kind of funding opportunities that you noted that come, to the health center, say, or to whatever program is providing the training and education. So it's like workforce grants and things like that. But then you also have opportunities for the learners themselves to receive, say, like education funding and things like that. And so is there kind of an optimal space where you can have like opportunities for learners to receive funding for their education and possibly as a health center find financial support?
That's a great question. I think it varies a lot from state to state what that looks like. I do think right now looking into those workforce funding sources and what they're making available. I'll say when we're working in partnership with health centers that have tapped into apprenticeship dollars, it's kind of the best of both worlds because we can help students access federal funding for tuition, and the health center can access those workforce dollars to help with supportive services. But there's a lot of variation about whether those dollars can actually support what the employer is doing in terms of employer contribution. I'll say the places where we're seeing the most support for the effort it takes for employers is in private foundation and grants, and where I think there's a real opportunity for advocacy at the federal level, or as you're thinking about, your infrastructure for teaching health center, is that something that can also help to support overall these health education and training initiatives with other staff. Also, that's the hardest piece to find, is the funding for that internal infrastructure that you need as a health center.
Okay, interesting. Thank you. And thank you again for the presentation. Real quick, I'm going to introduce our next speakers from the Louisiana Primary Care Association and the Louisiana Health Department. And I apologize. Let's see, Jance and Erica, I don't have pictures for you, but I'll let you introduce yourselves. But real quickly, I wanted to introduce Tracy Ingram, who works for the Louisiana Department of Health and manages multiple regions of their community health worker program. And then Susie Hutchinson, who directs the practice management and health center operations programs. And Mrs. Hutchinson has over 35 years of healthcare management experience and is certified through the American Academy of Medical Management as a certified administrator in physician practice management and medical staff recruiting. She's a graduate of the UCLA and Johnson & Johnson Healthcare Executive Program and formerly worked at the Louisiana Department of Health's Bureau of Primary Care and Rural Health, and served as the Practice Management Consultant Program Manager, where she's provided technical support and consulting services to rural health clinics, FQHCs, school-based health centers, and hospitals. So thank you very much for being here, and welcome also to Erica and Jance. And I will turn the screen sharing over to you.
Okay, and I'm going to try to do that.
Yeah. And if not, I'm happy to advance slides if you would like.
Okay. Yes, and as I told y'all in the beginning, Erica was the guru here, so I'm so glad she came. She was on another PowerPoint presentation to HRSA, in fact. So we've been singing this song for a while, but thank y'all for having us. Can you see the slides okay?
Yeah, let's see. Is there a presentation mode? Oh, there we go.
Yes. Okay, great. As you know, Tracy Ingram has worked with us as well. I can't say enough about Tracy. We have years and years of working together at the Bureau, and our pathways keep finding each other. And Erica, of course, Rose Crawford has been instrumental in our program with our community health worker development. So I'm not gonna let Erica, I feel terrible she didn't have her picture up here, but Erica, go ahead, and you want to kick off and tell them about this?
Sure. Good afternoon, everybody. I'm Erica Rose Crawford. I serve as Louisiana Primary Care Association's program manager for their community-based vaccination program, where we kind of address vaccine hesitancy in the community. We found that in Louisiana, we had a lot of COVID hotspots and a lot of vaccine hesitancy in those areas. And so what we went out and did, and we addressed the hesitancy by making sure if patients were going to give us a no, they were going to give us an informed no. They were going to know what they were saying no to. So we collaborated with these regional partners. Through this partnership, we were able to get our community health workers trained. They did 40 hours of community health work core curriculum through the Aaron E. Henry Community Health Center in Mississippi. So they did get a certificate of completion when they completed that training, and they were able to go out into the public and do outreach, being trained individuals instead of just lay people going out into the public and having a brief training from the PCA. Next slide. So this is kind of our program structure. So we were the centerpiece of all of these moving parts. We housed all the data, and we also hired community health workers who were contracted through Louisiana Primary Care Association, as well as had community health workers embedded in our FQHCs. The reason being is our FQHC community health workers would go out with their particular health centers in their service area and refer patients back into their health center. With the LPCA CHWs, they were able to do bi-directional referrals. They were able to refer those patients not only to the health centers, but if they had someone who was interested in getting vaccinated, but they live far away from a health center, they can send them to their local pharmacy to get that vaccination. So we didn't have to wait for them to schedule an appointment. If Ochsner was doing a particular program with us, we can send them over to get vaccinated immediately. That was the thinking for that particular model. We wanted to be able to capitalize on having the patient's ear at that moment and being able to get them vaccinated rather than waiting to schedule an appointment, because we know patients change their mind if they have to wait or schedule some time in their day to go and get, a service done. So that was the basis for how we structured this program. We were able to have some of our FQHCs who didn't have the staff capacity to have a CHW to become vaccine sites. That means we would refer patients to them just to vaccinate them, or we would send a CHW who was contracted with LPCA to their health center to set up a table to bring more patients in. Through that program, we did offer the patients incentives. We offered them gift cards to get vaccinated, as well as the CHWs were incentivized as well. And local partners we partnered with was also Council on Aging. We had our own health fair where Ms. Ingram brought her team out, and we partnered with several other healthcare agencies to get these patients vaccinated. We had about 6 months to get 3,600 patients vaccinated. And as you can see, we did 5,600 vaccinations instead of the 3,000. So we were really proud of that short window of opportunity. Next slide.
And one thing, Erica, we can add in on here, we had 2 other grants with HCCN, the American Rescue Plan, and PCA, American Rescue Plan, and each one of them channeled different funding for different things. Of course, HCCN is directed, it was through telehealth. It was during COVID. So how do you get patients on telehealth visits? How do we teach them about remote patient monitoring? How do we also we were looking at places to build on there. And that program, even though it was great and it was doing good, we still did not reach our full potential till we could complement our other grants. And the same thing with PCA, American Rescue Plan Act. That community health worker was an RN who was educating patients. So we began to join forces at events and fairs. And Erica would say, we're going to set up tables at this way, where we would educate them first. We would teach them about patient portals, clinics near them, and other services that we did. And then we built upon the COVID vaccine. So I'll just say that we complemented each other by not using the same funding, but being able to show the connection. Erica.
Next slide. So piggybacking off of what Susie just said, we did use the Find Help platform, which is Aunt Bertha, to give those referrals to our patients, being able to bring up all the services that were available in their area and put it in a database, and then send them a text message referral to those services that we were offering. to make sure that we were giving out the same message, we made sure we use LDH messaging for our community health workers. We use printed materials. We also canvassed the community. A lot of our community health workers did social media events where they would get on social media and do a Q&A with people who would join their lives to say, hey, do you have any questions about the COVID vaccine? And they would answer those questions live and leave them on their social media, as well as give them information to get vaccinated. That was very helpful to a lot of the community health workers who were in rural areas and things of that nature. But we did also have our expert, as Susie said, Ms. Christy Henderson, who's an RN by trade, that went to the events with us, that if patients had questions that our CHWs just could not answer, because this is the age of information, patients are very informed. She was able to answer those questions for the CHW and go into details with patients who needed a little bit more understanding about what the COVID vaccine was, what COVID is, and where to get vaccinated and how it would affect them. Next slide. So what's on the horizon for the PCA when it comes to workforce? We have a new community health worker training grant. What the PCA has been tasked with is to train 280 students to become community health workers. We are partnered with Louisiana State University Health and Science Center, as well as LaShawn, Louisiana Network of Community Health Workers, and Delgado Community College, as well as the AHACs, to put this program on. We are bringing some of the seasoned workers into the LSU LaShawn cohort who get mentor training and supervisor training, because they already have that core curriculum. They're already seasoned and doing the work, but we want them to mentor the new students that come out into the workforce and teach them how to be effective community health workers, because we don't want to just offer them a program and not teach them how to do the job. Our new community health workers will go through the Delgado program, and they'll get the core curriculum as well as soft skills on how to start cold conversations with patients, how to verbal de-escalate a situation, how to conduct themselves in public, things like that. So we're really excited about this program. About 20% of those students will go into a registered apprenticeship program here in Louisiana, and they will get on the job training. So this is what's on the horizon for the PCA when it comes to kind of workforce and community health workers. We also have another grant that will work with this program. It's called the Delta Rural Workforce Grant, where we will be training 80 students to become certified in front desk, as well as, I want to say, billing and coding. There is an associate's degree with the billing and coding piece of that grant, and that is set to kick off within the next year or so. It's in its infancy right now. And I'll pitch it over to Ms. Hutchinson.
You're on mute. Oh, Susie, you're on mute.
You muted.
Okay, you may not have given me the power tools. See, I didn't do so well. Okay, thank y'all. The professional development piece, Eric and I both got a chance to go to the UCLA J&J Community Health Advocate Management Program. We learned a lot. We felt like if we were going to be managing our community health workers and doing more within, and now we're taking care of Medicaid Unwind. We're bringing more community health workers online. So we felt like we needed to step in that role to be able to even manage those programs better. So that was an opportunity for us that we took full advantage of. Okay, Tracy.
Okay. So at the same time that they were doing what they're doing, we were developing community health workers within the Department of Health and the Office of Public Health. So the first thing we started with is how are we going to think about community health workers? You know, that's pretty much an umbrella term, but we wanted the community health workers in the Office of Public Health to serve as the liaisons between the community and the healthcare organizations. You will see them called different by different names in different centers. Sometimes they're called navigators, sometimes they're called promotoras. They're under different name processes, but it's the community health worker is an umbrella term that is taking off federally and with CMS as well. Next slide. So these are our community health worker roles within the within the Office of Public Health. We had two big roles, which were resource coordination, because our second grant for this came from the COVID-19 pandemic, of course. And so that was a huge need that came up very quickly. And so resource coordination was a big part of that. So we did case management for people. We would get a listing of, okay, XYZ became positive and said they need resources to be able to self-isolate. And we'd get that information, contact XYZ, and bring them what they needed through arrangements with Volunteers of America, with Catholic Charities, with lots of different community-based organizations, be able to bring them PPE, their medications, if they were on Medicaid or if they had prepaid, things like that, food boxes through an agreement with Greater Baton Rouge Food Bank. We also did screenings for other resources needs along the way. Did they need after COVID, of course, you know, did they need education? Did they to further their education? Did they need home assistance with getting a home, things like that? There's a whole variety of services that we would screen them for during that resource coordination. Our secondary role was community outreach and education. So of course, we were out there quite a bit with the vaccination sites, as you know, Erica mentioned. Wherever there was a vaccination site, we tried to be there, to be on the ground, to say, hey, we can help with this. We can not only help with the vaccination process and providing information from Department of Health, but we can help with the logistics also of the vaccinations. So we did a lot around that. The third, we do general resource coordination. As we're moving out of the pandemic, we are working more on actual social determinants of health. Further forward, like, do you have cardiovascular disease, diabetes, things like that. So we are working in that direction towards the future. Next slide. This is a map of where our community health workers are across the state. We intentionally, in the second grant we were that we received in the COVID grant, we were able to extend out our initial program to every region across the state. So we are not in every parish as far as physically located, but we serve every parish across Louisiana. Next slide. So working towards sustainability, that was part of our role from day one about sustainability. How do we keep this program going? Because in my opinion, the worst thing you can do is start a program and then take it away from a community that really needs it and really relies on it. And I will tell you, just from personal experience, we being located in the parish health units, we've had nurse practitioners, RN say, you know, we can't get rid of your program. There's no way. I would leave before the community health worker program ended, because they see the difference that the community health workers are making. They feel comfortable referring people to the community health worker because they know that we're going to follow up. We have that value to that healthcare team. We have the value to the communities. And we have become a valued team member. We can provide information to that healthcare team that they may not know. such and such is homeless. That may not come out in a 15-minute visit with a provider, or a 20-minute visit, or, they're struggling with food insecurity. I say all the time, you can't worry about your diabetes if you don't have any food in your house, so that's one of the things that we talk about all the time is, what are those other social determinants of health? We can also help with access to appointments, reducing no-shows. One of the major things that we've worked on is Medicaid reimbursement. Because we're in the Department of Health, we do have a strong relationship with our Medicaid department. So how do we get this through to where we can use Medicaid reimbursement for long-term sustainability? With the Workforce Coalition, which is not only LDH, but also other partners like the PCA, like the LaShawn, which is Louisiana Community Health Outreach Network, the insurance companies, the managed care organizations, all formed a workforce coalition, and we work together on Medicaid reimbursement and how to make that happen. Our state got two 1115 waivers. That's the number of the CMS Medicaid state plan amendment that you have to do to be able to pay for community health workers, not only in regular doctor's offices, but in FQHCs and RHCs. So that has been in place, been put in place, which is a big win for our state. And now we're in the actual process of, okay, now let's operationalize this within Medicaid. And so we have people that are working specifically on how do we operationalize this within our EHR, within Medicaid payment, things like that, to get that rolling within OPH and outside of OPH into the clinics to make sure that's a smooth transition so that we can get more and more community health workers across the state. Of course, we address social determinants of health, and we are also for sustainability looking for additional grants to build the program, because I'm going to tell you, Medicaid reimbursement is not much. It's $18 a visit. It's not going to be the sole sustainability argument and the cure-all, but there are other things that it affects, your outcomes specifically, which better outcomes, more grant opportunities, things like that. I listened to lots of presentations on community health workers, and staff retention is a big major win for community health workers. Next slide, please.
Do we
Go
want
ahead,
to go
Susie.
into that since we're close on time, Alex? It
Yeah.
was more Medicaid.
Yeah, go
I
ahead.
think it would be good to jump in a little bit more on
Okay,
that.
sure. I'm so
available.
sorry. I'm
Yeah.
so sorry. Didn't mean to do
It's
that.
okay.
Okay. I'm
The
going
next
to,
slide should be Medicaid reimbursement.
yes, who it reads for. Yes.
So the reimbursement from the 1115 waiver spells out who can receive community health services. Beneficiaries with one or more chronic health condition, with suspected or documented unmet health-related needs, social needs, and automatically beneficiaries who are pregnant. In order to be able to bill Medicaid for services, the CHW has to have completed a state recognized training curricula, of which the LPCA is doing one of those, and LaShawn is LSU HSC is doing another state recognized training curricula. Or any individual who has a minimum of 3 hours of documented work as a CHW. That specifies specifically that the providers must verify and maintain that documentation. We're working with Medicaid on exactly what do you want so that we can prove that, so that billing goes smoothly. Next slide. Covered services, health promotion and coaching, assessment, screening for health-related needs, care planning with the beneficiary and their health team, and health system navigation and resource coordination services. That, helping them to get their routine preventative care, adherence to treatment, education, things like that. And next slide. Non-covered services, what you can't get paid for, but probably actually happens. Helping with enrollment and insurance navigator assistance. We never recommend one over another. We just help with, here's here's the way you can go about and choose one. Case management, because there are specific providers that are enrolled for case management. Direct provision of transportation, that's a whole different category of payment with Medicaid. And direct patient care outside the level of training an individual has attained. We are non-licensed. Community health workers are non-licensed healthcare professionals. So we are not going to be giving medical advice. We can direct them to medical education and things like that and help them make their appointments and make sure they follow up. But we don't say, you have to do this, because that's outside of our training and our scope. Next slide. Here's our billing guidances and the individual CPT codes that are billed for CHW services. There are group CPT codes. When you get to looking at the group CPT codes, of course, the reimbursement goes down depending on the number of people in the group. So it's not a lot, and the maximum reimbursement is 2 hours per day and 10 hours per month per enrollee. The things that we're trying, and this is incident to a visit or a referral by a supervising physician, a PRN or PA. So we're working on what exactly has to be in that referral process. What do you want to see Medicaid to make sure that flows properly? That is not going to be a standalone in the FQHC world, a standalone visit. It has to be incident to another visit. Both individual and group sessions are allowed. One of the things that we're working on and we're bringing up to Medicaid is, how do you know who's provided those 10 visits? Because it could be somebody, another center. So we're moving forward in that relationship and figuring that out with the billing guidance. Next slide. Here are the reimbursement guidelines. I'm not going to read that all out to you, but they do have to be ordered by a physician or under the supervision of a physician. And there's actually no provision, no restriction on the site, which we really wanted that because community health workers do their work at so many different locations. Next slide. FQHC billing, not that different than regular primary care billing. Group sessions limited. Clinical record billing must be documented. HCPCS codes, your T1015 codes, an evaluation and management code, and CPT code for the CHW services have to be there to receive reimbursement. Next slide. And these are important links. There's Louisiana's Medicaid's informational bullet. There's MedPAC's Medicaid coverage of CHWs. That's more across the United States. And Susie, is there anything you wanted to add about the billing? That's kind of your forte. Susie and I worked together for many, many, many years at the State Office of Rural Health, and the billing and coding was her forte, and the working with rural health clinics and FQHC in general was mine.
No, I would just say, as Tracy said, it's not the sustainability. You've got to prove this through social determinants of health, through care coordination and other methods that your managed care organizations and your other insurance plans will reimburse you on, because Medicaid's not there yet.
Yeah.
So, and that's it from us. We thank y'all for having us.
Chance, would you like to introduce yourself? I'm sorry that I did not introduce you before the program.
Oh, no, it's fine. Thank you, Tracy. So I'm Chance Malbrew. I am with the Louisiana Department of Health. I am the population health manager working with our community health waves and CHW program. So
Awesome.
Great job, you all.
Thank you.
Thank you.
Excellent. Yeah, thank you.
And I wanted to tell, on the last presentation that Elena did, you know how she has the breakdown of what route you take? I took the COO route from the CMA when I was a young girl and ended up in the COO route and clinic, but I also did a detour during billing and finance. But thank you. When you showed that, I thought, how true.
Very true.
That's fantastic. Oh, that's wonderful. Well, and I will, I think if our guests are okay with it, open it up if anyone has questions, questions or comments or thoughts. And thank you so much, and thank you for going into a little more detail on the billing. I'll start. It may end up being more of a comment than a question, I guess.
I went
but
through kind of quickly, but it is there.
yeah. Oh, it's great. I think one of the important things is that the site, the specific site is not a requirement. It can be out in the community, which I think is, as I've seen more kind of mobile care being done by more and more places, including health centers, that will probably be kind of an important feature going into the future, and kind of the longer term is the ability to bill for services that are done on site.
And telemedicine as well. I think that's going to be a key component of this moving forward, especially if we have any other mass sicknesses or anything like that. You know, as we learned during COVID.
And I know Erica can testify that they just do so much more than community health work. I mean, it's just so much more.
Yes, it is. It is a lot of hand holding, listening to patients. It is all of those things. So when you have someone who's going out in the community, you want to make sure that you have somebody that can speak to the community, as well as someone that they can trust, because the trust will establish whether that person is effective at all in the community. And if you have someone that's in the community and they're misinforming them or not giving their word and standing by their word, your program will not be successful in where you're trying to do outreach.
And I will say this, in our accountable care organizations, we have to meet those standards. Remember that to get our payments. This also prepares us under that patient-centered medical home model. And it helps us because we don't have missed payments and we have healthier patients. So those are all some good things that feed into the sustainability of this program.
Fantastic. Well, thank you again for sharing all of that, both Elena and thank you, Lori, for joining us, and then Susie and Tracy and Erica and Jance. Really appreciate having you all on. And we'll just work on wrapping up for the Learning Collaborative session here. But if anyone has any questions for the folks here, please raise your hand or come off mute or throw something in the chat. But as before, the coursework will be on the discussion board, just like last time, and it's going to continue with that cost assessment. And again, thinking about the costs and some of the things that have been brought up today with some of these programs. So something like, with the CHWs, you mentioned that to be eligible for the billing, they had to be certified through a state training or have 3,000 hours. Is that right? Of
Yes.
experience. That's a lot of experience. So that like cost benefit before you can start billing, it might be worth, paying to put staff through that training program. And so kind of thinking through some of the things like that, or on the MA side, where does, where do your needs as far as having control of the training versus being able to work with a partner, and how you're going to bring in learners and how that training is going to get paid for and everything, really kind of thinking through those costs and where your kind of greatest opportunity lies. And then next session will be May 16th. We'll be looking at partnerships, clinical rotations, and residencies. And if anyone has any questions, oh yes, and thank you. So Elena and Lori have put their contact in the chat, and their contact's also on the slide deck that'll be available. And so I just want to give one more thank you to everyone for joining us today. I think there should be an evaluation popping up on there for our attendees. And speakers, you don't have to worry about the evaluation. But for any of the attendees, if you can answer the few questions in the evaluation, that really helps us out. And and thank you, Tracy, for putting in your email as well. And I've got that on the slide deck for them. And then I have a couple of extra resources up here as well for some other folks that do MA and dental assistant training and things as well, if you want to get some health center thoughts on that. And then, of course, our STAR Center resources and the podcast. Helen's on today. She's hosted many of our podcast episodes and does a great job. If you're looking for some resiliency related resources, I really recommend that. And then the STAR Center newsletter and our contact information. But thank you everyone for joining us today. And one more time, a huge thank you to NEMA and the Louisiana PCA and Louisiana Department of Health. And thank you for the presentations and also the work that you're doing, because that is the most important part of the patient care, is just the community interaction and the medical assistance and the people who kind of make all of that possible. So thank you very much.
Thank you for inviting us.